So we move to the next talk by Dr. Bancha. Dr. Bancha has been to Nagpur many times. We've interacted a lot, and we feel he's more Indian to us than Thai. So thank you, Dr. Bancha, for accepting the invite, and please go ahead with your talk.
Yeah, next time you give me the green card for Indian. Yeah, I will be Indian people. So thank you, the Indian Arthroscopy Society, for the kind invitations. So today I'm talking about the recurrent dislocation in hyperlaxity patients. Yeah, I think this is quite confusing when I was resident. Yeah, because at that time my teacher always talking about the MDI, you should do it in conservative way, right? This is my medical student. She came and asked me, so Prof, what's wrong with my shoulder? I can't do this way. Yeah, do I need to fix it? I said, oh, this is the laxity. You have some laxity. It's not your problem. You just can show that to your friends, right? But it's not the problem. You have no pain, right? So this is the laxity. So what is joint laxity? Joint laxity means this is increased length and elasticity of joint restraints. Get a degree of articular surface translation, right? And hyperlaxity is not same like instability. Hypermobile joint is a ball on the wall with laxity in all directions, right? Like this guy, yeah, he can do that because this is a hyperlax joint, but it's not the problem, okay? So hyperlaxity is asymptomatic hypermobile joint. We should not confuse with the MDI. Instability is a symptomatic laxity, so it's totally different. So MDI is about 10% in all instabilities. Male is less than female. Okay? So that can be congenital and can be acquired joint laxity. MDI is a symptomatic laxity in at least two directions. Okay, like inferior anterior, like the first scenario. This is inferior anterior, right? You have the sulcus positive, okay, and also the patient have the hyperabduction, is painful, okay, and apprehension positive. This is the anterior inferior. The second scenario, this is the inferior posterior, okay. This patient have the Kim positive, yeah, Kim test positive. Is so much pain in this position. So this is the inferior posterior, okay, yeah. So another situation is the anterior, posterior, and inferior. But important that you need to have inferior component, right? Like this patient have both symptoms in anterior and also the posterior, okay? So this is a Pagnani valence classifications about the MDI. So they classify into bond loose, torn loose, and acquired loose. Okay, the first group is the syndromic, the bond loose. This is like the congenital MDI. So the patient would have global instability in all directions, like earlier than loss, Marfan syndrome. This is a collagen problem. So the second group is the torn loose. Torn loose, the patient start with the asymptomatic laxity, and this kind of patient may have the active in sports. They have the repetitive injury. So finally, the lax capsule, lax tissue would get labral tear. So this is a torn loose, like I show you in the pictures, right? This is the hyperlax joint. You see the patulous capsulolabral recess, and one day the labrum start to be torn, right? So this patient will come with pain. And the last group is the acquired loose. So this kind of patient have the multidirectional laxities after repetitive microtrauma, like they are active in sports, overhead sports, and when you look in the intraoperative, you can see no labral tear. Okay, so these are the three groups, yeah, by Pagnani valence classification. I show you the first patient. This is type 1, the true MDI, or we can call the syndromic MDI. This patient have congenital MDI. They have global instability, subluxation, dislocation in all directions. The Brighton score weighs more than 4. Okay, so you look at this patient. They have a lot of scar tissue in the shoulder. She was operated many times, right? But she still can do the subluxation of the joint, okay, after the surgery. So you look at her shoulder. This is both shoulder. She have the more than 4-5 times, yeah, every operation, a lot of ankles in the shoulder, also lataje, but that cannot, yeah, finally we did they did the biopsy. They found that this patient is earlier than loss, okay. So every operation will be failed in her shoulder, okay. So don't touch this kind of patient. This is a syndromic true MDI. So the second group is the MDI, that is the MDL, multidirectional laxity with labral tear. So this guy have the labral tear, okay, from the arthroscopic findings. So they start with the asymptomatic MDL, but after the repetitive or single macro trauma, they have capsular laxity or redundancy with labral tear, okay, like this, okay. So actually this guy, I met him 6 years ago. Yeah, at that time I'm taking care of the rugby team. So at that time had dislocation at the scene, but the mechanism of injury is not bad. So this young boy, okay, you see, this young boy, 6 years ago had dislocation, but I treat him conservatively because I think that he has a MDI, is that just laxity. So he has no problem 6 years, but until one day, he has so much pain and the dislocation become more. So finally, this MDI, okay, become MDI with labral tear, okay. So I did the surgery for him. When I get in, I found that there's a patulous recess, you see that, and the label is torn, right? So we do the surgery for him. We do the pancapsular labelplasty like that, and he's quite happy after surgery, okay. And the last group is the MD type 3. This is the acquired loose. So this kind of patient, they have the MDL with repetitive microtrauma like swimmer, gymnast, racket sports, basketball. So this kind of patient would have no labral tear, or they may have some labral crack, right? So like this patient, you see that there's some labral crack, like Kim lesion, but no obvious labral tear, okay? So this is the type 3, the acquired loose, okay? So important thing is that when you dealing with this type of patient, you need to see that this is voluntary dislocator or is involuntary. Look at this young girl, right? She has the involuntary dislocation, but her problem is the scapula, you see? Yeah, when I move, I push her scapula back to the chest wall, so the subluxation is gone, okay? So this is an involuntary dislocator. So I train her muscles, and we make a scapular muscle training, and she's become better after that, okay? It's not dislocate anymore. So this is the importance of the periscapular muscles and the conservative treatment. The clinical signs of MDI is different in each patient. Some may come with the scapulothoracic problem, okay? They decrease the strength, they have numbness, tingling sensation, dislocation in mid-range, and sometimes the mechanism injury is very minor, is not appropriate. So if you have this kind of patient, thinking about the MDI patients, and also the bone loss in this patient is very minimal. There will be no heel sac, no bony bankart in this kind of patients, right? So examination, first we need to make a good exposure to always see the scapula, because many times the patient have the periscapular muscles problem. Like this lady, she has wing scapula. Check the cervical spine every time, and also the brachial plexus, okay? And let the patient show you how they can do that, okay? So assess the shoulder range of motions, Titan score, right? Is that more than 4? Or you check the laxity test, yeah, laxity test that the laxity that not produce pain, like drawer, sulcus, hyperabduction of the shoulder, painful hyperabduction test. You're thinking about instability also, right? Apprehension, O'Brien test, Proce apprehension test, Kim test, right? So Kim test for me is quite reliable for the posterior inferior labrum, right? If the patient have this test positive, you look at the this one, yeah, that's produce pain if the patient have the posterior inferior instability. So look at the arthroscopic. This is a classic pictures of the MDI. You have the really large capsule, right, like that. Okay, and also sometimes you can see the concealed lesions on the labrum, right, especially the posterior inferior, right. So I didn't agree with this paragraph. They say that the MDI, you may have the significant bone loss or you may have the large Hill-Sachs lesion, but in my experience in MDI patient, I rarely have the bony lesions like large Hill-Sachs lesion or bone loss. Okay, so if I saw the patient have the multiple dislocation, it's very easy dislocate and multiple dislocation like more than 10, and you have no bone loss. So thinking about the MDI patients, right? So we always start with conservative treatment first. We control the pain, we stabilize the scapula, and also restore the rotator cuff strengthening muscles, and also sport specific training. So I show you one patient. This patient, she's have very loose joint. So after 6 months of the conservative treatment, she's doing very well, and her sulcus size and also the instability test is getting much better. So I think we give the patient some time, right? And conservative is always the primary treatment for this kind of patients. So when should we operate or when should we not operate? Yeah, I think not operate is more important, because if you operate in the wrong patient, you have problem, right? For this MDI patients. So the operative indication is the patient that failed conservative treatment more than 6 months, and the instability that associated with labral tear or bony lesions. The goal of surgical treatment is to restore the labral height, to tighten the joint capsule, balance the loose ligament, and address the labral pathology. So examination under anesthesia is quite important. We need to check it every time before the surgery. Yeah, to check the directions of the dislocation. I prefer this TU supine position because yeah, it's quite easy, and also you can do the surgery without intubation, right? Awake surgery. Patient can go home right away after the surgery, and you have less gravity effect. Yeah, because if you put the patient in lateral decubitus, you need to lift up the axilla all the time, right? So this TU supine position is quite useful in my practice. I always do only 3 portals, right? I start my posterolateral portals. We call this Kim's portal. Kim proposed that, right? The posterolateral portal, anterosuperior portal, anteroinferior portal. Right? So in this supine position, this portal will be parallel to the floor. See that? Yeah, this is the posterolateral Kim portal. You can see very well. And then we start with the anterosuperior portal. It's just underneath the AC joint, and anteroinferior portal is just above the subscapularis. So you always see that the patient would have pateroscapsular recess, right? Widening of the rotator interval. Okay, and now you switch your scope to the 6 o'clock position. So I show you this. This is the Kim lesions, or it's a concealed lesion. So from the MRI, you cannot see any tear from this the hidden lesion, right? This is very common in the patient that have painful jerk or Kim test positive. In my practice, they will have labral crack. It's not like labral tear. Okay, it's just crack. It's a hidden lesion. So the next step is to refresh the repair. I don't like to do the capsular plication because in my practice the result is not so good. So in my practice, I will do detach like that. Okay, from 6 o'clock, okay, to 3, okay, and sometimes to 9 o'clock. It depends on the degree of instability. Okay. After that, we put the anchors. Start from 6 o'clock. I prefer to use the double load anchors, like that way. So we start from 6 o'clock, and then we go to the front and the back, and finally we close the rotator interval. Okay. like that. And I also close the portal because I don't want to have any defect in the capsule also. So after the surgery, I always close my portal, okay, like that. Yeah, this is like a pancapsuloplasty in the patient that have very loose joint, okay. So this patient is the MDI without label tear, okay, the class 3. So you can see from the x-ray that the patient have the very loose joint from the examinations, sulcus positive, and excessive external rotations, and load and shift test also positive, okay. So you look at the x-ray, you see that the patient have the severe sulcus sign positive, okay, from the examination. So this patient, we treat her conservatively for 2 years. She still have problem. She have numbness, tingling sensation, cannot carry anything. Yeah, it's so much pain. Yeah, and she asked for surgery because we treat her for 2 years. She still have problem. And every time we check the x-ray, we found that she has persistent subluxation. So after the surgery, the patient getting much better, and this is the x-ray after the surgery. Okay, we can reduce the inferior component, right? So this is the MDI without label tear. This patient have the MDI with anterior instability. The patient have hyperabduction test, yeah, and also that's painful. Anterior apprehension positive, Kim positive, sulcus side positive, and Bison score is 7 from 9. So we did the same way. Okay, we call this the capsuloplasty. Okay, and cross the rotator interval also. So after the surgery, even we do a very tight, you see that we repair the capsule very tight. So after surgery, the patient getting much better, and the sulcus sign is becoming better. She had full range of motion after surgery, and she's quite happy with that, with the result, right? So this is about 4 months after the surgery. So we never have a single patient that have stiffness after the surgery. Even if we do a very pancapsuloplasty, right? So the next patient, this one, he has the painful, the skin test positive. You see that it's so much pain. He has the MDI with a posterior instability, this patient. So we get in and we found that the patient have, you see that there's the posterior labrum is quite red, okay, and also labral crack in the back. So this patient, we do the capsuloplasty. We starting from 6 o'clock to 9 o'clock, right? We didn't go too much to the front because from the examinations, I found that the anterior instability is not so bad. So I stopped at 5, 6, 7, 8, 9, right? I stopped like that, yeah? We didn't do it routinely. It's depending on the patient's symptoms, right? So after the surgery, the patient quite happy, has good motions, and also the Kim test now is negative, okay? So next patient, this one is the MDI with anterior and posterior shoulder instability. He's a thrower, right? This one. Yeah, so we did the same ways. We do the pancapsuloplasty from 3 to 6 and 6 to 9, okay? You also have some labral tear, right? So after the surgery, yeah, we did that way, okay? And that's the results after the surgery. The patient doing much better. This is about 2 weeks, yeah, 3 months after surgery. The range of motion coming back, right? The patient also happy with the results, okay? And the sulcus sign now is becoming better. So be careful when you're dealing with the MDI. This should not be happening to you, right? The failed MDI patients. Also, this patient have the voluntary posterior subluxations. Okay, she has done anterior surgery, posterior surgery, lattache, bone block, everything. Okay, but the shoulder still fail. Okay, after surgery. Yeah, like this guy, this lady. Yeah, she's suffering from the surgery, and I dare not to do anything in the shoulder. She's referred from one hospital. Okay, So I give you the take-home message for this MDI. So MDI is not the MDL, it's different. MDI is the MDL, multidirectional laxity with symptoms, right? So you should know that it's born loose, it acquired loose, it is torn loose. Is it voluntary? Is involuntary? You have a scapulothoracic problem or not? So we always start with a conservative treatment for the patients. Okay, so wait. You should wait for this kind of patients. Some respond very well. Okay, but some who did not respond from the conservative treatment, you can do the surgery. Okay, but you need to judge how much you do. You do pancapsulolepoplasty. How much you do that? Okay. The capsular application in my hand, the result is not so good. I prefer to do pancapsulolepoplasty or capsular reconstruction. Okay, thank you.